So hello friends, welcome to another session of CE recall based questions. So today we are going to discuss about CE pharmacology. My name is Dr. Pravin Prasad. I am presently working as an assistant professor in Department of Clinical Pharmacology, Marginville campus, Trivandrum University. So let's stick together. So our first question here would be drugs means. It's a very short question, okay? So this question has its roots from Guide to Good Prescribing. It was given by WHO in 1994. It's a very old concept, but it's still relevant today also. So if you want, though the dates are not important, the concept is that even if you have been taught about hundreds of drugs during your undergraduate training, but still you will be dealing only with the 30 to 40 drugs. So if you are dealing with only 30 to 40 drugs, you want to get acquainted with the different aspect of those drugs. So, and these 30 to 40 drugs, the list of 30 to 40 drugs are personal for you, for the prescriber. That's why P drug would stand for a personal drug. So this is our answer. One more important question that can come from this topic is, what are the criteria? What are the factors that you want to consider while choosing a personal drug? So there are 4 factors that you need to consider: efficacy, safety, suitability, and cost. So this is another important question that can come in your exam. So let's go towards the next question. Okay. So our second question is, the drug of choice in case of postural hypotension is. So there are 4 options: clonidine, propranolol, fludrocortisone, and phenylephrine. So let's understand what this postural hypotension is first. So postural hypotension, it occurs when a person changes his posture, that is from sitting goes into the standing. So in this scenario, what happens? There is a peripheral pooling of blood. Because of the peripheral pooling of blood, the baroreceptors, it needs to send impulse. The stretch is reduced and it needs to send impulse to the central nervous system. From there will be a sympathetic outflow that is going to constrict the blood vessels and increase the blood pressure. But in case of postural hypotension, this phenomena is not occurring. So here what you need to do is, you need to either increase the sympathetic discharge or you need to increase the blood flow. So there are 2 mechanisms how you can treat these patients. So if we talk about our options, clonidine, it's an alpha 2 agonist. It blocks the sympathetic outflow, so this cannot be our answer. Similarly, if we talk about propranolol, it's a beta blocker. It's going to decrease all the activities of beta receptors. So again, this cannot be our answer. Talking about the phenylephrine, yes, it's a vasoconstrictor. It's acts through the alpha 1 receptors. It causes vasoconstriction. But the main problem here is that it has no beta activity. So once it has no beta activity, it is going to cause vasoconstriction. It is going to raise the blood pressure. Once the blood pressure is being raised, it is going to cause reflex bradycardia. And with the reflex bradycardia, it is also another problem with phenylephrine is that when you are giving phenylephrine at clinical doses, it has no significant blood pressure increasing effect. So because of this, we are left with the option fludrocortisone. So once there is increase in blood volume, the problem of postural hypotension will be decreased. So that's why here the answer would be fludrocortisone. So now let's move towards the next question. So our next question is, which of the following is the most common side effect of salbutamol? So options are hyperkalemia, hypoglycemia, tumor, and tachycardia. So let's go towards the let's deal with this question. So as we all know, salbutamol is a beta 2 agonist, and once you are giving this drug, it is going to act on the skeletal muscles and it is going to activate the sodium potassium ATPase pump. So once the sodium potassium ATPase pump is being activated, all the potassium that is present outside will be moved inside the cell, and this is going to cause hypokalemia and not the hyperkalemia. This side effect is important when you are using this drug salbutamol for the premature labor, when you are giving it at a high dose. So in addition to that, also salbutamol is used for the treatment of hyperkalemia. So it is a very obvious thing that salbutamol causes hypokalemia and not hyperkalemia. So this is not our answer. Similarly, if you talk about the hypoglycemia, so ideally if you see beta cells in the islets of Langerhans that is present in the pancreas, it is stimulated by the beta 2 receptor is going to cause stimulatory action on it. So whenever there is stimulatory action, it is going to cause increased release of insulin. So whenever there is increased level of insulin, it is going to cause hypoglycemia. But let's stick together, let's wait. It is also stimulating the alpha cells, and from the alpha cell it is going to cause release of glucagon. So this glucagon is going to increase the blood sugar level. Additionally, it is also going to act on the liver and is going to cause glycogenolysis. So it is going to break down all the products and trying to bring more and more glucose. So here also, because of this, it is going to cause increased blood sugar. So ultimately what will happen? The person will have hyperglycemia and not the hypoglycemia. This side effect is important because at times when a person is having salbutamol, if the person is also diabetic, the insulin requirement of those patients might go high. Another option that we have is the tumor. Now, salbutamol, it is known to activate the beta 2 receptors. Because of this, there is a asynchronous activation of the slow contracting fibers of the hands. Additionally, there is increased discharge from the muscle spindles. Because of this asynchrony, because of this multiple stimulations, it is going to cause tremor and not the tumor. So, tumor is not our answer. Then the last option would be tachycardia. Salbutamol, though at low dose it is a beta 2 agonist, at high dose it can also activate the beta 1 receptor. So that is one mechanism of tachycardia. Another mechanism of tachycardia would be because of the activation of beta 2 receptors, it is going to cause vasodilatation. So once there is vasodilatation, so it is going to cause reflex tachycardia. So with salbutamol, it can cause tachycardia by both beta 1 as well as beta 2 action. So the answer here would be tachycardia, D, tachycardia. So now let's go towards our next question. So our next question is, digoxin toxicity can be precipitated by, and there are four options: hypokalemia, hyperkalemia, hyperglycemia and hypercalcemia. So this question is directly related to the mechanism of action of digoxin. And as we all know, digoxin, it mainly acts by binding to the different receptors. Which receptor is present in the cell membrane? So let's zoom in and find out the answer. So it mainly binds to the sodium potassium ATPase pump. So this center one is the sodium potassium ATPase pump. So what is happening here is digoxin and potassium, they bind on the extracellular phase of the sodium potassium ATPase pump, and there is a competition going on between digoxin and potassium. So whenever there is low amount of potassium available, the digoxin can easily bind to the sodium potassium ATPase pump and can inhibit them. So because of this, there will be increased activity of digoxin, or the person can have digoxin toxicity. So now we have our answer, that is the hypokalemia, but let's understand why other options are not correct then. So whenever there is hyperkalemia, the first thing that you can understand, you can obviously find out here is that whenever there is increase in potassium level, there will be again competition between digoxin and potassium, and the binding of digoxin will also be inhibited. It will not be able to bind so easily. So once it is not binding so easily, the effect of digoxin will decrease. Additionally, whenever the digoxin is going to increase the atomicity of the fibers, those all increased atomicity will also be decreased by the potassium, by increased level of potassium. So hyperkalemia will decrease all the effects of digoxin. So this is not our answer. This can never be our answer. Talking about the hyperglycemia, it is not related to digoxin toxicity. You can just remove it. Then talking about the hypercalcemia, usually what happens is whenever there is increased calcium in our blood, there will be increased calcium in the myocytes also, and because of this there will be the activity of digoxin will be enhanced or increased. So it is not going to enhance the digoxin toxicity, but it is going to show the synergistic effect with the digoxin. That is one explanation. Another thing, it would have been better if the question was formulated with hypocalcemia as an option. But however, if this question comes again in your exam, then in that scenario, we would like to stick with the hypokalemia and not the hypercalcemia, because even if this question comes, this is going to synergize. It's going to show synergistic effect with the digoxin, and is not going to increase the digoxin toxicity, or it is not going to precipitate the digoxin toxicity. So whenever we are talking about the digoxin toxicity precipitation, we want to stick with the hypokalemia. So this will be our answer. So now let's go towards our next question. So our next question is, atropine and diphenoxylate are used in combination because, and the options are to decrease its abuse, to ameliorate its side effect, to potentiate its action, to increase its onset of action. So if you see the combination of diphenoxylate and atropine, diphenoxylate is an antidiarrheal drug that is commonly given if a person is having non-infected diarrhea and multiple episodes of diarrhea. So here the problem with the diphenoxylate is that it is an opioid, and additionally it is going to cause the blood-brain barrier. So if it is causing the blood-brain barrier, it can show central effects, and also it has a abuse potential. So the problem here is that it has an abuse potential. So what to do now? So whenever there is an abuse potential, you want to combine with a very low dose of atropine. So what will happen if you combine with atropine then? So whenever a person takes multiple tablets of this thing, diphenoxylate, so in that scenario, the person will also have a high dose of atropine being taken unknowingly or unintentionally. So whenever there is high dose of atropine that the patient is taking, so it is going to land up with the atropine effects, and these atropine effects will be unpleasant. So whenever the effects are unpleasant, in that scenario, the person will not take multiple tablets of diphenoxylate. So that's why our answer here would be to decrease its abuse potential. Now let's go towards our next question. So our next question is, according to FDA drug risk classification, if there are no adequate studies in pregnant women, animal studies lack and have shown an adverse effects on the fetus, it falls under which category? The options are category A, B, C and D. So as we all know, FDA category, we have 5 categories from category A to category X, and category A is the safest drug, category X is the contraindicated drug. Okay. So what are the basis of this classification? So there are 2 main bases. One is what is the available human data, and the one was the what is the available animal data. So if you talk about category A drugs, we already have data available from human studies, and they show that there is no risk to the fetus. So once this data are available, you don't want to wait for the animal data, so you can give it safely to those patients. So here the options would, and some examples would be magnesium sulfate and thyroxine. Similarly, if you talk about the category B drugs, here the human data is available and they fail to show any risk to the fetus. So here I have used the word seen. No risk to the fetus is seen. However, animal data has shown that there is some risk to the fetus. One scenario would be that. Second scenario would be there is no availability of human data, but the animal studies, they have shown no risk. So with this combination also, they have been categorized as category B, and the example in this would be penicillin B, paracetamol and lidocaine. Similarly, if you talk about the category C, here the human data is not available, and if you talk about the animal data, either it is not available or it is available and it shows the risk in the fetus. So in both scenario, it has been kept as category C, and the examples would be morphine, thiopentone and bupivacaine. But in this scenario, why do you want to use these drugs then? Because it has a high potential benefit. If you move down in the ladder, if you go to the category D, there is evidence of harm to fetus seen in the human studies. Human data is available, and with this, what happens is, once you have seen the harm in the humans, you don't want to wait for the animal data. So the example of this group of drug would be aspirin and valproate. However, still you might want to use this drug because it has a high potential of benefit to the mother. Then moving to the last category, that is the category X. Here both human study as well as animal study, they both are showing harm to the fetus. So once they are showing the harm and then they have a high potential of risk, you don't want to use them and they are contraindicated. And the drugs in this category would be estrogen and thalidomide. So here if you refer back to our question, that there is no adequate studies in pregnant women. So we are either it is talking about B or it is talking about C. So now let's see what else is present in our question. Animal studies lack or have shown an adverse effect on the fetus. The second part. Now if you see our table here, either it is available, sorry, either it is available and it has also shown risk on the fetus. So because of this, the answer here would be C, category C. So let's move towards our next question. So our next question is, which of the following drug is given prophylactically before giving cisplatin? So cisplatin is an anti-cancer drug, and as we all know, anti-cancer drugs, they are very much notorious for their adverse drug reactions. Some of the adverse drug reactions are so severe that they cause the dose limitation. You cannot go for the higher dose of those anti-cancer drugs. If you talk about folinic acid, it is mainly given if a person has received methotrexate. Once you are giving for methotrexate followed by folinic acid, so what you can do is you are rescuing all the rapidly multiplying cells like bone marrow cells, epithelial cells, and skin and hair follicles. So because of this, you can go up to 100-fold increase in the dose of methotrexate. So folinic acid it is given with the methotrexate. Then if you talk about the folic acid, it's not a commonly used drug to decrease the dose limiting adverse effect of drugs, because it is an inactive form, and once you are giving some anti-cancer drug, this folic acid cannot be converted into folinic acid. The use of folic acid would be, it can be given in combination with the 5-fluorouracil to increase its efficacy. Okay. Then let's talk about Mesna first. Mesna, it is commonly given with drugs like cyclophosphamide. This cyclophosphamide group of drugs, they are known to cause cystitis. So to decrease the side effects of cyclophosphamide group of drug, you want to combine with Mesna, that is given systemically. Another option that you can use to decrease this cystitis is you can give locally, you can give a drug called acetylcysteine. So you want to irrigate the bladder with acetylcysteine, that's going to decrease the cystitis caused by cyclophosphamide. Now the remaining option is ondansetron. Cisplatin, as you all know, it's a highly emetogenic drug. So whenever you are giving some highly emetogenic drug, you always want to combine with antiemetic drugs. So commonly the drug that is the drug of choice for chemotherapy induced nausea and vomiting would be ondansetron, as has been given in our question. Addition to that, you can also go for metoclopramide. Sometimes if the vomiting is so severe, in that scenario you might want to use some adjuvant antiemetics like lorazepam, like glucocorticoids, and another new drug that is aprepitant. Okay, so answer here would be ondansetron. So one more thing that I would like to add up here is use of doxorubicin. So doxorubicin is also going to cause cardiotoxicity, which can be decreased by giving a drug called dexrazosone. So it's an iron chelator. It can be used to decrease the cardiotoxicity of doxorubicin. So let's go towards our next question. So our next question would be, angiotensin converting enzyme inhibitors cause cough by increasing the level of, and the options are serotonin, bradykinin, histamine, and acetylcholine. It's a very straightforward question. The answer is bradykinin. It's a very commonly asked question. However, let's understand the mechanism or the explanation behind this question. So ACE inhibitors, they are known to inhibit an enzyme called angiotensin converting enzyme 1. Okay, so what is the normal mechanism or normal use of this ACE enzyme then? So they are known to convert angiotensin 1 into angiotensin 2. Okay, so what is the use of angiotensin 2 then, or what is the use of ACE inhibitors? So they are commonly used for the treatment of hypertension, they are commonly used for the treatment of congestive heart failure, and they are also commonly used for the treatment of diabetic nephropathy. Okay, so these are the three main indications of ACE inhibitors. Now another thing that this angiotensin converting enzyme, because it's a very non-specific enzyme of the multiple reactions that is going to inhibit, it is also going to cause the breakdown of bradykinin into inactive peptides. Now once you are inhibiting ACE enzyme by giving ACI inhibitors, this bradykinin will also not be inhibited or will not be broken down. So now you have lots and lots of bradykinin in your lungs. What is this excess bradykinin going to do now? So it is going to increase the sensitivity of sensory nerves, it is going to increase the substance P, and also it is going to increase the prostaglandin. So once all these things are happening, ultimately what it is going to do is it's going to cause the increase in bronchoconstriction, as well as it is going to produce chronic non-productive and brassy cough, which is very typical of ACE inhibitors. So this is the mechanism how bradykinin is going to cause is responsible for the ACE inhibitors induced cough in patients. So now let's go towards our next question. So our next question is, which of the following function does cyclosporin A primarily inhibit? So whenever you talk about the cyclosporin A, you want to talk about the immunosuppressants. So if we talk about the immunosuppressants, we mainly are going to talk about two group of drugs. So there are multiple immunosuppressants. For now, for this question, two group of drugs that you need to understand. One is tacrolimus and cyclosporin A. Another one is sirolimus and everolimus. So this tacrolimus and cyclosporin A, they are known to inhibit the calcineurin. So they are also known as calcineurin inhibitors. Then when you move towards the sirolimus and everolimus, they are a different set of drugs that is going to inhibit a different enzyme or different protein molecule that is known as mammalian target of rapamycin, mTOR inhibitors. Okay, so this is the difference between these two group of drugs. So now if we talk about the tacrolimus and cyclosporin, how they are inhibiting this calcineurins. So normally cyclosporin A, it enters the cell and binds to a molecule called cyclophilin, and this complex is going to inhibit the calcineurin protein inside the cell. Once this calcineurin is inhibited, it is going to cause a cascade of events, and ultimately what is going to happen is there is no production of interleukin 2. If you talk about tacrolimus, the another name of tacrolimus would be FK506. Okay, so this tacrolimus, it is going to bind to a protein called FK binding protein. Why FK? Because tacrolimus is also known as FK506. It is binding to a protein, so it's a FKBP. Now this FKBP, it will go and get bound to the calcineurin and it will inhibit the calcineurin. So ultimately both the drugs, cyclosporin as well as tacrolimus, they both are going to inhibit the interleukin 2. Whereas sirolimus and everolimus, they come and play after this production of this interleukin 2, and this is going to cause T cell activation. So this part is inhibited mainly by the sirolimus and everolimus. Okay. So in our question also, we have 4 options: macrophage function, antibody production, interleukin 1 production, and interleukin 2 production. And our answer here again would be interleukin 2 production. Okay, I hope we are clear with this question. So let's move towards our next question. So the last question for today would be, which of the following is true about the adrenergic beta receptors? So there are 4 options: CAMP receptor, GI receptor, GQ receptor, and GS protein. So normally what you understand here is CAMP is a secondary messenger, as not a receptor. So this is not going to be our answer. You can just cross it out. So now we have 3 types of receptor options remaining: GI receptor, GQ receptor, and GS receptor. Now if you all remember, beta receptors are stimulatory receptors, and if you talk about the remaining options, GI is an inhibitory, whereas GS and GQ are stimulatory. So we can also remove the GI as a possible answer. So now we are left with the 2 options, GS and GQ receptors. So if you remember, beta receptors, they mainly increase the activity of CAMP inside the cell. They are coupled with the CAMP. So if they are being coupled with the CAMP, it is going to bind to the and is going to increase the CAMP. So it has to be the GS protein. Now you might ask, the answer is protein here, but we are talking about the receptors. So the receptor molecule itself, it's a complex that is made up of protein. That's why even if the question says GS protein or GS receptor, the answer will be the same. However, this GQ receptor, it mainly acts through the IP3 DAG pathway. So this IP3 DAG pathway is not the by which beta receptors is going to act. So just a quick review, if we talk about the different types of beta receptor, alpha adrenergic receptors. So alpha receptors, alpha 1, alpha 2 and alpha 1A, 1B and 1C, they all are stimulatory and they act by the GQ receptors. Okay. Then we have alpha 2 receptors, they are inhibitory. Okay, we have 2A, 2B and 2C. They mainly act through the GI receptors. So as you can see here, they are going to decrease the level of CAM. If you talk about the beta receptors, all three beta receptors, they are going to increase the activity of CAM. So because they are increasing the activity of CAM, they will all be GS receptors. As you can see in the slide, sometimes they can also directly combine with the calcium channels. So I hope the answer is clear. The answer here would be GS protein. So that would be some of the questions from CEE Pharmacology, and I hope you enjoyed staying with me, and if there are any queries, please reach out to us and we'll be happy to answer those queries. See you again. Thank you.